Fantastic. Okay, so welcome to this session on improving capability and skills in the health and social care workforce. My name is Pia Clinton-Tarrastad. I'm Head of Commissioning Policy and Resources at NHS England, and I'm just going to facilitate this session. We've got two fantastic speakers here today, Liz Bryan and Deborah Holman, who both work together at St Christopher's Hospice. Liz is a lecturer practitioner, and Deborah is the advancing practice nurse and social care lead. And their perspective is kind of how the third sector can support and help with workforce development. We've heard over the last 24 hours about some of the challenges facing the health and social care system over the coming years, some of the demographic challenges and the financial challenges. We've also heard some really enthusiastic and encouraging work around how we're improving experience for patients and better integrated care. But reflecting on this morning's discussion, there is this probably increased fragmentation at an organisational level now in terms of social care, bits of healthcare, public health, primary care and so on, and other sectors. And kind of what does that mean really for how our workforce needs to develop, not just in terms of skill mix and what types of workforce we need, but also culture and attitudes. And I'm hoping Liz and Deborah can give us some real insights into that. We'll open up to a panel discussion after the presentations, and really keen to have a kind of broad discussion about education and training and what works and how we change attitudes in the workforce. So I'll hand over to Liz.
Just click on the thing, do I believe so? Oh, I've gone too far. Is that right?
Yep.
Okay. Hi, welcome. As Pia said, I'm Liz Bryan. I'm a lecturer practitioner between King's College London, the School of Nursing, and St Christopher's Hospice. And I'm also one of the advancing practice nurses at St Christopher's and have been there since 2007. My background, in fact, is in, obviously I'm a nurse, but I'm also trained as a psychotherapist. And it was during my training in psychotherapy that I became particularly interested in education and learning and how we develop adults in practice. So that's how I sort of stepped then into education. And so you will notice that my focus is very much on emotional learning, which in the area of end-of-life care, of course, is very pertinent. So I'm going to tell you about a programme that we designed at St Christopher's Hospice. It's called QELCA because that's easier to say than what it used to be, which was end-of-life care programme for generalists. And it stands for Quality End-of-Life Care for All. Yep. That's it. So what do? Press really hard. Yep, okay. So just a brief history of QELCA. The programme developed in direct response from a request from a local acute hospital who were concerned that they'd had quite a lot of complaints around care delivered at end of life. Particularly issues they were concerned about were poor communication with patients and a lack of recognition by the nurses of the needs of the dying patients and their family. We were asked if we could take all the nurse managers from the 10 medical and elderly care wards on a week's placement, but they couldn't come together, obviously, because of backfill. So they were going to come in groups of 4. They were also going to send their PDN and 3 matrons. So in total, we had, I think it was 16 band 7s and matrons over 4 weeks. And we thought, well, okay, placement is fine, but actually we need to provide a more structured programme. So we designed a 5-day programme, which was 3 days in the classroom and 2 practice days sandwiched. They were in small groups of 4. There was high facilitation on the classroom days, a lot of work done on reflection, on prior learning, prior experience, trying to make sense of what they were seeing in the hospice, and then leaving the hospice on day 5 with an action plan, and to follow that up with action learning back at the hospital over 6 months. Okay. So, also, as you can see, the end-of-life care strategy, which was published in 2008, this request actually came before that was published. But you can see even, fair amount of time before Francis, the end-of-life care strategy was highlighting that end-of-life care was is below standard. There isn't a consistent quality of end-of-life care across the UK. So there were already concerns. Are we going? We're not moving. Yes, we are. Okay, that's fine. So I've run through the programme. It's doing its own thing. Just to explain, I did tell you about the programme, but what's innovative, I think, particularly about this programme, is that it relies on specialist nurses role modelling the values of hospice care, not just in the practice setting, but also in the classroom. So that person-centred or student-centred model of learning. And the nurses that deliver the programme are not necessarily educationalists. They are specialist palliative care nurses, using skills that they would use in their practice, facilitating maybe family meetings or multidisciplinary meetings, listening, being able to draw out the students' learning, and to challenge them as well as support them through that process as they change attitudes. This isn't, oops, it's got a little bit of a delay. So we had an initial success. That original programme was very well evaluated. In fact, it was overwhelmingly well evaluated. And we were intrigued as to why it seemed to have had such a dramatic impact on the ward managers that attended. So we did share the findings with the King's Fund, and they gave us a small a pot of money to do to repeat it, but with another acute trust and some community nurses. And we evaluated that, and that was the findings were released in 2009. But since then, we were approached by Help the Hospices and the National End of Life Care Programme, which has now become part of NHS IQ. And we were given some money to roll it out and pilot it across England. So in 2012-2013, QELCA was delivered across 17 sites. 17 sites by 21 hospices to a total of 137 acute nurses. And the evaluation was undertaken at 4 stages. It is an education evaluation. It's not a piece of research as such, although I think that the findings are interesting, and it is worth us continuing to roll it out, I think, because what became apparent and the main area of learning is if you want to access these slides, you have access to the evaluation report there, which I think some of you might be interested in. But the main change that was reported by nurses appears to be attitudinal. All the nurses who participated reported subsequent positive changes in their practice, particularly their communication skills, improved in communication with colleagues. They felt empowered through their learning to challenge medical colleagues. Greater knowledge of drugs used in end-of-life care, and the most, I think, interesting development, a greater emotional engagement in addressing the needs of patients and their families. So, in summary, hospices are third sector organisations in the main, and they deliver high quality care, but are underused, I believe, as a resource for training and education for the NHS. And I'm increasingly convinced and convicted that hospices around the country should combine and look at developing training resources and programmes that could be accessible by NHS workforce. Thanks very much.
Thank you, Liz. And changing culture and how you do that through education is one of the real challenges facing us. It comes out in the Francis recommendations, and that's what we need to do, change culture and attitudes. And yet actually the how of doing that is really hard. So hearing about some practical examples is great. Attempt to sort... You're not medicines optimisation, are you? Let's have a look. Is it you? Just have to press that one quite hard. This one. Yep. So over to you, Deborah. Thank you.
Good afternoon. I'm Deborah Holman, as has been said. Been at St Christopher's as an advancing practitioner as well as a specialist palliative care nurse to start with for about 10 years. Have a background in district nursing for about 8 years before that. At my time at St Christopher's, have spent about 5 years delivering gold standard framework into care homes. And in the team with Liz, really, about developing practice and education. So very much my heart, my theme, my passion is about helping people to die at home, if that's what they choose to do. And very much my focus and everything that I've done very much over the last sort of 20 years is around that, really. So this project, when it came up, really pressed all my buttons. And in this time, obviously, can only just focus on one part of it, and that's really about the capability and the skills of the social care workforce. In district nursing, when I was district nursing back in the 90s, health and social care were very much together, and have since, of course, been parted. And what I really am passionate about is bringing it back together, because you've got to have it together if you're going to enable people to die at home. You can't really have one without the other. And so we were approached by a local borough in 2012 to put together a business plan for developing some kind of domiciliary care for people to enable them to die at home. And so it was a 14-month pilot project. And it was set up in response to the data that in the local borough of Croydon, they had higher than the national average of hospital deaths. And the lower than the national average number of deaths in the usual place of residence. And so the main aims of this project, which we set up, was really about reducing inappropriate hospital admission at end of life. In that last year, we know that in the last year of life, many people have 2 or 3 hospital admissions. So we're trying to reduce inappropriate hospital admission at end of life, and also to enable people to die at home if that's what they choose to do. And so one thing that we really had to focus on was recruiting the carers and building the right kind of workforce that could enable us to do that. We advertised purposely for kind-hearted people. One of the difficulties in having kind-hearted people is then that you have to teach them how to be resilient. But we advertised for kind-hearted people, and we felt very much that we would not be able to assess a kind-hearted person in a 20-minute interview. And so we set up assessment days. We've run 4 or 5 assessment days over the first 8 months of the project. And when we brought them in for the assessment days from 9:30 till 4:30, we would do literacy and numeracy testing on them. Now, unfortunately, some people fell at the first hurdle. And it's very apparent that if we're going to develop a social care workforce, we've got to take a step back and perhaps help some people with their literacy and numeracy in developing people into practice. We looked at trying to gain insight into their social skills. We looked at their attitudes and opinions, their motives for wanting to be a carer. And we did that by having group activities, team building activities. We actually had a really fun day. Having group interviews, trying to get from them not so much what they know and understand about social care, but actually what are their opinions about things, what are their attitudes about things, how do they treat people, how did they treat us on that day, would that reflect how they might treat other people. And we found actually doing an assessment day and bringing people together has been a very good and successful way of trying to find the right kind of people for this kind of work. Usually there would be 2 or 3 of us who would be running the assessment day, and we would always sit down at the end of the day and agree together who we felt were the people to take forward then onto an induction week. And we would bring them in we started off with 5 days, then we reduced it to 4. We gave them all their mandatory training. So moving and handling, safe food handling, information governance, all their mandatory training. We introduced them to the National Minimum Training Standards, that was what was on the table at the time, and of course we know that might change going forward. And we also began to think about how we would develop a program of training. One thing that's very apparent for the social care workforce is that because they are not a recognised body as nurses are, that there is no kind of formal set process of education and development for them. And so we wanted to try and provide something ongoingly for them. So on top of that, once we had approved them through the induction week, it was only at the end of the induction week, we didn't pay them to come on the induction week, we gave it for free. At the end of that week, we then decided who we were going to carry on and take on to the service. At 20 hours of practice with a nurse, with myself or my colleague, or one of our senior carers, with a criteria of what we expected them to have learned and observed and been seen to be competent in within the 20 hours. They come to mandatory monthly supervision, which means that we spend half that time doing further teaching and training and half that time doing reflection in practice and how we can develop them as individuals. We have developed a QCF Level 3 award in awareness in end-of-life care, which we've now changed from our previous training. As you'll know, QCF training is now the national standard, and so we're beginning to put them through this program, and now we're looking at doing QCF medication management. Medication management, as I'm sure you're aware, is very difficult in the social care sector, and teaching and training social carers to do medication is something that we really want to do, but we've got to make sure we get it right. And so just looking very briefly at our outcomes for the first 12 months, 70% of people who wanted to die at home did so. And you know the national average is 21.4. How did we do that? Well, I've got all sorts of thoughts of my own how we managed to do it, but I think one thing that was very apparent having health and social care together is that being a nurse-led service, we were able to have those difficult conversations up front, straight away. Where do you really want to be at the end of your life, and how can we make that happen for you? Thinking about DNARs, thinking about ACPs is our bread and butter. That's what we do. And so it was something that I think was very key. Health and social care together, 70% of people dying where they want to be. 7% of people said they wanted to die in the hospice, and they did so. Of the 23% of people who died in hospital, none of those people had expressed a desire to die in hospital, but they were admitted to hospital for a very valid reason, either an acute episode or an expectation of further treatment. So, that's it in brief, and maybe out of some of this we can take some questions.
And I wonder first, I just want to check from the People's Panel whether there are any questions you would like to raise. Please do.
Yes, thank you. I mean, I think they sound absolutely fantastic because all of us in the room are absolutely certain we're going to die one day, and we'd like some kind of choice about what it's like, and also to make it as easy as possible for our families. Perhaps people on the People's Panel have got a closer flirtation with death than other people in the room, shall we say. Certainly I've had close encounters. I really wanted to make a comment. Am I the only person who was shocked that nurses in acute hospitals didn't know how to approach dying people and their families? I mean, I was absolutely gobsmacked. I thought that was a sine qua non of being a nurse, and maybe what we actually need to do is, I mean, I think it's great what you're doing, and please carry on doing it, but maybe we should go back a bit further to their education and training and their selection.
Liz, any thoughts on that?
Yes, I agree with you completely. It is shocking. And as somebody who works 2 days a week in a university, it's something I feel very strongly about. There's so much to get into the pre-registration curriculum. And of course, the focus will always be, or tends to be, on learning how to keep people alive. So the focus will always be on acute care. I think attitudes are changing. I think as we recognise that we are going to have a very large population of older people with long-term conditions, that actually our skills in healthcare need to change. Of course we need people who are skilled in acute care, but we will need people who are skilled in health, training patients to be more independent and in health literacy, but also in enabling people to talk about what they want and how they want to live their lives, choices that they want to make, rather than just assuming that professionals know best. Of course, professionals need to understand that they also need to hand over those responsibilities. So yes, I mean, I think unfortunately, the end-of-life care strategy that was published in 2008 was a bit of an eye-opener for a lot of people, but it had been, I think there had been quite a few people who were aware that care, particularly for the elderly in acute hospitals, was below standard. Yeah.
Sorry. Yes, just really to echo what Sue said. Also, yes, obviously we're all going to die one day. We want to die with dignity. We want to die where we want to die. But closer to home for me at the moment, my father had a fall, broke his hip 3 years ago, went into hospital, had a stroke, which we've only just found out he had. We knew he had, but nobody would back us up. He's absolutely, I mean, his health is declining rapidly. My mother is completely immobile. She's not really in the position to care for him. I live here, so I have to keep going down there at weekends and things. And, you know, the overriding thing that my father, the message I'm getting from him is that he doesn't want to go back into that hospital atmosphere. Yeah. He doesn't want to die in hospital. And just from seeing him before, when we thought he was going to die the last time he went into hospital, there was such a distinct lack of empathy, a lack of care, a lack of understanding for how we felt as his family. So I think the work you're doing is absolutely fantastic, and just to see those statistics of once people have done the training, to say they feel much more empowered to question clinicians' decisions, the fact that they feel so much more confident in their communication skills. These are basic things that people should be feeling from the beginning. So it's not, to me, it's another example of where we're not working in a joined up way, and we should be, because until everybody starts to learn to do that, we're not going to, you know, little pockets of people like you doing the fantastic work you're doing, but, you know, if everybody doesn't do it, we're going to not move on from here. And the whole message about these 2 days has been about making the changes, moving on. So while I applaud you for what you're doing, and I think it's fantastic, I'm kind of now thinking, well, my dad doesn't live anywhere near it, you know, and I want him to move now so that he gets the care that you're providing. So, you know, well done, but I'm very kind of sceptical about it moving on.
Do you want to answer that?
I think, I mean, it's good that we are able to explore good practice. We've got this small project. It is only a small project. 200 hours a week is our maximum. In saying that, we've just launched into another borough now who have seen what we're doing and are interested. But I think, you know, the bottom line is we've got to prove that we can do it. There are many boroughs that don't have a 24-hour service, and so there's going to be those gaps where people are vulnerable at home. We can't be in people's homes all the time. It really has to be collaborative working with district nurses and other services that are out there working together to enable people to be where they want to be. And so I think, you know, this is an example of good practice. We've still got a lot to learn. We've still got a lot to develop. And I think, you know, it's something that we can showcase in that sense.
I think also, I mean, St Christopher's Hospice is the largest hospice in the country, and it has a tradition of being involved in education and research. And so, if anyone's going to be a pioneer in this area, it will be St Christopher's. However, we're wanting to share what we learn. We're determined to share what we learn. You know, death and dying is what hospices do, and we do it well. But we only care for, well, it's about 7% of the population who are actually dying. So it's a tiny proportion. So 93% of the population will not have specialist input. I think it's about 5% of the population will actually die in a hospice. So I think that the end-of-life care strategy was a bit of a wake-up call for the hospice movement, because we haven't really achieved what we set out to do, which was to improve dying for everyone. And I think that we've changed our attitude dramatically since the end-of-life care strategy, in that we're now saying, okay, we are going to have to spread ourselves more thinly. We can't have this deluxe dying for a tiny proportion of the population and then let the rest get on with it. We need to be much more influential. We've learnt a lot about how to care for dying, what they need, what skills we need in order to enable that. So we need to try and share that more effectively. And that's why both the projects, I mean, particularly the QELCA programme, you know, trying to get partners, so help the hospices. Obviously, there's approximately 220 other hospices in the country, and the National End of Life Care Programme, so that's the NHS improving quality, and it's ultimately it will be about education commissioners, so Health Education England, seeing third sector organisations as a viable alternative to delivering education. So they need to commission us to do it, because we're charities, so we can't do it for nothing. So, you know, that's the mantra, really. You know, we are the experts. We're happy to share our expertise, but you have to send people to us for education.
Thank you. A question over here and then at the back. Sorry, at the front first and then, yeah. Thanks.
Thank you. Well, as one of the other 222 hospices in the country, I just want to make one question and one comment. First of all, thank you. St Christopher's is an amazing place in terms of it returns a bright idea and then implements it. I have a question for you, Deborah. Could I just clarify for me? You talked about the carers. Did you set up a domiciliary care agency, or did they work? How did they work? And then I've got a question for Liz, if that's okay.
Yes, we set up. I suppose we have set up, in a way, a domiciliary care agency. We've only got, for that first year, we had 2 contracted carers, and the rest are on 0-hour contracts, because obviously it's work when it's available. So yes, we have.
Thank you, because I think that kind of fed into my point that Liz says that one of the things that hospices are doing is setting up domiciliary care agencies. St Giles and Lichford is another example. And it goes back to this influencing beyond the walls. But my other question for you, Liz, is that you described that QELCA, which I think is brilliant, and we're looking at it in Hertfordshire, that there are all these pockets of good practice throughout the country. How do we join all this up to get commissioned by Health Education England? Because there is loads of stuff that's going on, but it's not being joined up.
No, another area that I think is worth exploring, and that is about the hospices becoming perhaps a little bit more of a lobbying, or body. And certainly we're exploring with Help the Hospices the idea of perhaps becoming more of an education consortium so that we can share resources, because the hospices all around the country are delivering education. They're usually putting on their own bespoke programs that they've designed. We're probably all saying exactly the same thing, but all doing our individual work designing those courses. And I think we need to have a sort of consistent, standardised message. There are plenty of these vocational qualifications. This used to be the NVQ, but now is Qualifications Credit Framework. There are sufficient units there which are nationally accredited. It's actually the quality of delivery that's the problem. That we have some FE colleges and we have independent education providers who are claiming to deliver end-of-life care education to health and social care workers by e-learning. One of the most dramatic and shocking adverts we saw was for a train the trainers for people to deliver end-of-life care education in one day. Now, and no previous experience required. So, unless we get the quality assurance of these QCF qualifications right, unfortunately we can't guarantee that people who've got certificates are actually going to be fit for purpose or fit for practice. So, I think there's lots of work to do, and I think we certainly are becoming increasingly political and realising we need to be lobbying, we need to know what's going on around the country, and as third sector organisations we can't just be on the fringe and just delivering to our little locality. We need, as you say, to become more joined up. Thank you.
That links me a bit to what I was going to say. The care homes
Yes.
are a major issue, and I'll give a personal example. I've lost both my parents in the last year. My mother was 88 in a care home. They're both in the same care home. Both had dementia. She was 88, and the night that she was dying, the matron was on, and she was palliative care trained, and beautifully done. Sat there, we were all there, it was absolutely great. 6 months later, my father is in the same situation, and we had spent 2 hours filling in a DNAR form, which isn't called that anymore, I can't remember what it's called, but a great long name. Taken us 2 hours, it's pages upon pages of pages of decisions, and I'd sat and gone through all this saying, we don't want to admit it to the local hospital, which doesn't have a good name. We discharged him twice from there before. We don't want him in there. He just wants to die. He's 92. He misses my mother. Went through all this. We filled all the form in. And it came to the point of him dying. And this time there was a very nice staff nurse, middle of the night, very nice staff nurse, but she obviously felt insecure. And the GP says he has to be admitted. So I'm in London. So I got in the car. I drove 6 hours to Blackpool, got there, went in, said to her, please don't admit him until I walk in the door. So got there, sat there and said, we do not want him admitting. What are they going to do in acute hospital? He's going to have to go through A&E, all the rest of it. And she was fine, because I was there. And I sat with him day and night for 2 days until the matron, who was palliative care trained, came back on duty and said, I tried to ring her, she was on holiday, came back on duty and said, this is ridiculous, of course we won't admit him. But the bit for me was, most people, I'm not being funny, will die in care homes now. And there is this absolute thing about, if they start to go off, they decide they'll send them to A&E. Now, some of the A&Es keep them for an hour and send them back to the care home. But the potential is that they'll admit them. And there is nowhere worse for somebody, 92, dementia, aggressive, than being thrown into the middle of an acute ward. So I just wondered, Liz, if there's any way, I mean, looking at, some of this is about social care staff, because of course some of the homes are both, to try and extend it out, because that's a group.
Yeah.
Well, and they're private companies, so I mean, they should be able to purchase the education.
No,
it's a real issue when you're stuck in the middle of it.
We have actually just piloted QELCA in a care home in South London, and it worked beautifully. It was fantastic. It was a large care home, and they have subsequently asked us if we would train some of their staff to be trainers of QELCA, because they're now considering becoming a teaching care home so that they can bring staff from other care homes to learn how to manage dying. And the number of their residents who are now dying in that care home has increased. I don't know the figures. And of course that gives huge job satisfaction to the staff. Because I think one of the things that I feel very strongly about is that nurses are increasingly feeling under quite a lot of pressure, feeling got at. You know, there's a lot in the press, there's a lot in the media about how they're not getting it right and they're not compassionate, and of course a lot of them, most of them are compassionate, but in fact it's the systems often within their organisations that are preventing them from delivering the care that they want to. And over time they get worn down. And what QELCA certainly enables them to do is to step out of that environment, come and talk about some of those barriers in a safe environment, and to go away a bit more empowered to go and tackle some of those issues, and to do it as a group, because that's the whole point. We bring band 6s and 7s from the same organisation and do the action learn with them in that organisation. So the idea being that they can actually make change happen together. They're a bit more of a sort of corporate voice.
Just something about care homes. I mean, St Christopher's has been working in care homes for 30 years or more, and certainly over the last 5-6 years have done a lot of work with Gold Standard Framework in care homes. And in the 5 boroughs that surround us, we have something like a 76% death rate of people dying in the care homes, very high. But it's also very labour intensive. One of the disadvantages for care homes is the high staff turnover. And so you can provide an awful lot of education and training to people who then maybe leave and move on. Some of the care homes that we worked with Gold Standard Framework that I worked with might have had 3 managers in 1 year. And so there are difficulties within the context of care homes as well about sustaining education. And one of the things that we've tried really hard to do is not just deliver education, but look at how to sustain education in care homes. And that ongoing, and very much, I mean, my feeling in education, apart from the classroom delivery, is you've got to show people how to do it. Show people how to be compassionate. Show people how to deliver care with dignity. And so very much in the social care project, I go out with them and I work with them. This is how we do it. And I don't think we can learn end-of-life care from e-learning. I don't think you can learn it necessarily in the classroom. What QELCA and this programme is doing is very much doing it alongside role modelling and showing. And I think, that it's the difficulty with education is how do you measure it? How do you say this is value for money? It's very difficult. But education can't be something you deliver once. It has to be sustained. And care homes have their own difficult context. And I'm sorry you had that experience.
We've got time for one last question. Speak up, because there's no mic.
Holman Minford, end-of-life care facilitator and educator. I just want to go back to tie up a few of the things that were said earlier, and I think somebody was shocked that nurses, 1 in 4, I think it was, in 2010, were scared to broach the subject of death with a patient or carer, and having been involved in training pan-London of doctors and nurses over the past year in end-of-life care, it is absolutely still the key thing. And I feel there's a whole plethora of training, some of it excellent, some not so excellent. But how do we really centralise, a lot of what you're saying is about this, how do we really get that this approach of training that's attitudinal, that's relational, and it's helping to dismantle the taboo around death, and it's the societal impact as much as anything, because I think we who work in the area do tend to forget that a lot because we're so used to working in the area. But how can we get that more embedded into pre-reg training programs for medical and nursing staff and social care staff? I think that's, and I know you've been answering some of the things about hospices, commissioning it and so on, but I would love to know how to push that forward in a big way.
Yes, I think you would think, wouldn't you, that we'd be able to talk about death and dying in our, we seem to be able to talk about most things, but we had a really interesting experience this summer. We tried, part of our development of these QCF qualifications, we put on a summer school for 16 to 19-year-olds. So like a sort of pre-employment type introduction to social care. And we invited schools to nominate pupils to attend. And we had about 19. They were all girls. We were surprised. We thought we might have some boys, but they were all girls. And we introduced them to patients in the hospice. We did a goldfish bowl, which is where you have a group of patients who are in a discussion which is facilitated with the students sitting around the outside. We did some art therapy and exercises with these young people and patients in the day centre. We had some students from the Brit School performing arts who had come in and had been working with the patients, looking at sort of getting the patients to tell their story, and then they enacted it in drama and dance, and these students watched this. And one or two people said, "Oh my goodness, how can you do that with 16 to 19-year-olds? Well, you must need to be careful. You're going to traumatise them." They absolutely loved it. We had tears, particularly from those that maybe had a poorly grandparent, but with a lot of support, and in an environment that is, sort of normalising, and with brave patients who are willing to talk about things honestly, and they did. Talked about, in the goldfish bowl, talked about what it feels like to be told that you've got an incurable, life-limiting condition and to live every day not knowing whether you were going to die. They talked very openly and honestly about it, and the students responded extremely well. And on the last day, it was a 5-day programme over 3 weeks, the QCF the quality assurance people came in to witness and saw the students actually doing post-its about what they'd learned and about what they wanted to do for their future careers, and were, I think, pretty amazed at how mature these young people were and how passionate and excited they were at the prospect of becoming health and social care professionals as a result of this experience. So I think we need to be a bit bolder. And I think, the end-of-life care programme did talk about raising public awareness and getting debate going, and there's initiatives like Dying Matters, and, I think we just need to start not being quite so timid.
Thank you. No time for more questions. I think it's a great message to leave it on. Thank you very much to our People's Panel and for coming in. Big thank you to Liz and Deborah for the fantastic work that you're doing. Thank you.